telling us certain aspects of the recent advances in corneal diseases and imaging and therapeutics. So I, on behalf of the scientific committee, welcome you all to this session. So we have chairperson with us, Dr. Namrata Sharma. I'm sure she's going to join us in a short while. Then co-chairperson, Dr. Vanati. I am Dr. Samrat Chatterjee. Co-convener is Dr. Sharad Gomse, who's also probably will be joining us in a short while. And Dr. Revati Rajaraman is with us also. So we'll wait for a couple of minutes till it's the official time, although someone's asking us to start it. But let's give everybody a benefit of time. Dr. Mukesh Joshi is here. Dr. Antonio Carlos. Dr. Othmans.
Good evening, everybody here. We welcome you to this special session on celebrating 200 years of Indian ophthalmology with doyens of ophthalmology. This is a special Cornea edition of this series of seminars which are happening here, and we are happy to welcome all the speakers who have come from abroad, and I hope you will have a wonderful session in the next 3 to 4 days, and you will enjoy your stay here in Indore and in India. I think we will now, without any further delay, start our session here. Our opening speaker is Dr. Anshu Arundhati. She's professor at the Singapore National Eye Center and a very eminent cornea surgeon with wide experience in both clinical and research work and in eye banking as well. We welcome you, Anshu, to our wonderful place. She's, of course, from India here. It's very happy to have you here with us and talk to us about anterior segment imaging. Thank you, Anshu, for taking out time to join us, and over to you now.
Thank you very much, Vanati. At the outset, I would like to thank the organizing committee for inviting me here for the All India Ophthalmology Society conference. I'm indeed delighted to be here, back in home country. anterior segment imaging is a huge topic. In the interest of time, because I've been allocated 8 minutes, I'll be focusing mainly on anterior segment OCT, ultrasound biomicroscopy, a little bit on specular microscopy, and confocal microscopy. As we all know, anterior segment OCT or optical coherence tomography is a non-contact, non-invasive, in vivo high-resolution cross-sectional imaging of the eye that measures backscattered light. It works on the same principle as the ultrasound B mode imaging using light instead of sound. Essentially, it involves creation of a series of A scans that combine to produce this ASOCT image, and it produces cross-sectional images of the cornea, the sclera, the iridocorneal angle, as well as the lens. And there is quantification software provided to measure the corneal thickness and the angle of the anterior chamber. There are several prototypes available. Visante OCT is a prototype of the time domain anterior segment OCT, which allows for greater penetration through tissues that highly scatter light. Example, through opaque cornea, limbus, or sclera. It can be integrated with the Atlas topographer to provide anterior and posterior surface topography as well. We also have the spectral domain ASOCT, the OptoView, which provides for better resolution but reduced penetration. So it can actually map out these different corneal layers, and it provides also high resolution posterior segment imaging. So what are some of the applications of ASOCT today? It's used in normal corneas to measure corneal thickness, for screening for refractive surgery candidates, as well as for glaucoma patients. And in most studies, it has been shown that anterior segment OCT, the corneal thickness measures less than that of the ultrasound corneal thickness with a very good repeatability and reproducibility. In corneal surgery, it's very widely used, especially in cases of corneal decompensation, where preoperatively we use it to assess corneal thickness. And then post-lamellar keratoplasty, for example, DSEC, we monitor resolution of edema as well as lenticule detergence over time. So this image here shows a patient with a graft rejection post-DSEC, showing a thickened DSEC graft. And when we started this patient on topical intensive steroids, 1 week later, his corneal or the graft or the lenticule had thinned out significantly. It is used widely in preoperative screening for patients with corneal scars and opacity to assess the depth of scar in order to plan types of DOLC surgery. So if the opacity is very, very superficial, in the first 100 to 150 microns, we can do, and if the opacity is smooth and there is no significant surface thinning, we can do procedures like automated lamellar therapeutic keratoplasty. If the depth of the lesion is, say, mid-stromal or deep stromal, then we do what is called as manual or big bubble DOLC. But if it is almost like a predecimetic scar, or in cases of hepatic keratouveitis, we need to exclude endothelial compromise, then ASOCT is a valuable tool. Similarly, in keratoconus, it is helpful to determine the overall thickness profile and the area that's the thinnest on the scan to determine our dissection. It also helps to exclude DN scarring secondary to acute hydrops. Ultrasound biomicroscopy is also an imaging modality based on the emission of an acoustic pulse and reception of the pulse after it has reflected off the ocular surfaces. It also images the cornea, the iris, and the iridocorneal angle structures. And using calipers, we can also measure several parameters like the AC depth, the corneal thickness, and the interspur distance. It is a high-resolution UBM can also penetrate through opaque media, and this has a very significant role in the management of pediatric corneal opacities. The image acquisition requires the eye to be immersed in a fluid with an eye cup, and this can be a little bit uncomfortable, and the contact nature makes it impractical for evaluating eyes with trauma as compared to an anterior segment OCT, and it requires a skilled technician. So typically on a UBM on a normal eye, the most important landmark is the scleral spur. The other structures that can be visualized is the anterior and posterior part of the cornea with the intervening stroma, the angle or the iridocorneal angle, the ciliary sulcus, the ciliary body, the zonules, as well as a little bit of the pars plana. It has several quantitative and qualitative assessments that it can be used in to measure corneal thickness, the angle, the anterior and posterior chamber depth, the IOL thickness, iris, ciliary body, and scleral thickness, as well as the sulcus to sulcus length, which is critical when you're planning to put in ICLs in the eye. Qualitatively, it is used to determine the mechanism of glaucoma, primary or secondary. In trauma cases, it is useful to assess zonular integrity and the position of the lens. And it plays a vital role in evaluation of the anterior segment in the presence of significant corneal opacities, especially in pediatric cases. It's helpful in evaluating tumors in the iris, the ciliary body, and the pars plana area. Also, it can help to determine reasons for inflammation post-op, to determine if the IOL is in the bag or is it in the sulcus, and also to determine ocular inflammation in patients with episcleritis and scleritis. So these are some of the images of patients who we've used UBM in. So this patient here, as you can see, there is forward bowing of the iris and a closed angle, which after laser PI opens up with a flattening of the posterior bowing of the iris. This is a 4-month-old baby who had bilateral corneal opacities. One of her eyes had significant corneal opacity and a very disorganized anterior segment. And intraoperatively also we found that the lens in the cornea was adherent, and we had to do a penetrating keratoplasty for this eye. The fellow eye actually had a significantly reasonably good anterior segment anatomy, and we were able to do a deep anterior lamellar keratoplasty for the baby. Very routinely, we use UBM for patients who have asymptomatic iris cysts, and we review them every year to make sure they're not developing any secondary symptoms from the presence of the iris cyst. This was a middle-aged patient who presented to us with non-specific symptoms, and on examination was found to have a ciliary body melanoma. Moving on to endothelial imaging, specular reflection, the endothelial cell layer, as we know, has a different refractive index from the aqueous humor. And by utilizing specular reflection, light is reflected back to form an image of the endothelial cell layer. There are several types of specular microscopes available, but in the interest of time, I'm just going to skip this. Essentially, when we look at a printout of the specular microscopic, we have to be able to interpret all these values and on the right-hand column here, and what do they all mean? So this is the cell density, which measures the amount of cells, and we know that with age, there is certain decrease in cells, and the average adult cells is about 2,400 cells per millimeter square. Coefficient of variation indicates the degree of polymegathism. If it is greater than 30, it indicates that there is significant polymegathism. 6A, or the percentage of hexagonal cells, should be, if it is less than 50%, again it indicates significant pleomorphism, or the number of cells that have 6 sides. Clinical applications, as we all know, it's used in Fuchs endothelial dystrophy, pre and post corneal transplantation, in iridocorneal endothelial syndromes, and in posterior polymorphous corneal dystrophy to monitor patients over time. So as an example, this is a patient with Fuchs endothelial dystrophy who's got significant guttata in the visual axis, which appear as dark spots on specular microscopy, and as they progress and expand, they distort the surrounding cells, and typically the endothelial cells in the early stages tend to be more normal in the corneal periphery. Moving on to confocal microscopy, which is an optical imaging technique to allow in vivo imaging and microscopic examination of all layers of the cornea. The most important feature of it is its ability to make optical sectioning of the visualized structure. So this is a typical confocal image of the normal human cornea. This is showing you all layers of the epithelium. The superficial epithelial cells are characteristically rounded with hyperreflective nuclei, which is also seen in the intermediate winged epithelial cells. Whereas in contrast, the basal epithelial cells are hyporeflective, surrounded by a hyperreflective border. This is the Bowman's layer, which is acellular with subepithelial nerve plexuses, and this is the stroma with keratocytes. And finally, the endothelial cell layer, which is a monolayer of endothelial cells. Typically hard to visualize Descemet's membrane on a normal cornea, but when it's scarred, it can be easily seen. Again, mainly the clinical applications of confocal microscopy have been in infections. Other roles are in evaluating the limbal stem cell in patients with limbal stem cell deficiency. It has a great role to play as a research tool in patients with post-LASIK and SMILE, where you evaluate the response of keratocytes as well as post-cross-linking. So this is a patient who was suspected to have Acanthamoeba keratitis. His cultures were negative, and then we did a confocal microscopy to see these typical double halo or signet ring appearance of the trophozoites. The cysts are usually seen as round or ovoid hyperreflective structures, and they're typically larger than the leukocytes but smaller than the keratocytes in the eye. And it has a sensitivity of 100%, but a specificity of 84% in detecting Acanthamoeba. But we all know how tricky it is to look at these images because of hundreds and hundreds of images to be looked at. And it also depends a lot on the technician and the patient cooperation. It's also used in patients who have culture-negative fungal infections, and we suspect that they may be fungal in nature. It can be used as a tool to evaluate the hyphae. And in contrast, the hyphae tend to be growing vertically, whereas the corneal nerves, which vary from 5 to 20 microns in thickness, have a sharp margin if they are in the stromal nerve or a beaded appearance if they are in the subbasal plexus. And they can detect fungi with a sensitivity of 94% and a specificity of 74%. Thank you.
Thank you, Dr. Anshu. Now let's go for some interesting history. I call upon Dr. Sharula Dharmaraj to talk about the Asia's first ever exclusive eye hospital, RIO, and its connection to the world's first eye hospital, Moorfields.
Thank you very much for inviting me. And it's a little bit of a digression from normal anterior segment stuff to take you to the land of history and things that have brought us thus far. Because it's rather exciting to have been in both the oldest eye hospitals, both at Moorfields currently, and I studied at the Regional Institute of Ophthalmology, which had the first eye hospital, as a medical student, and later on to do my postdoc as well. It's also interesting to note that although we might have belonged to the oldest eye hospital, a few other eye hospitals in India are also quite old. And the first old ones were seen both in Calcutta and in Bombay. So going back to the history a little bit while he finds my presentation, is the fact that long ago, 200 years ago, ophthalmology wasn't the most sought after specialty even in England. So I'm going to sort of paint the picture to you, for you, as to how ophthalmology was in the 18th century and the early 17th and 18th century. So this tells us a little bit about who was born at this particular time. You might recall John Ruskin, the novelist. It was also the same year that Queen Victoria and Prince Albert were also born. But for us in the medical world, it was rather exciting because this dentist managed to give us ether and so brought us surgery that was painless. It was also the year where we lost James Watt and Daniel Rutherford as well. Now, Clara Schumann was a very beautiful composer, and she made fantastic music, but she wasn't as well known as her husband, who's the Schumann we often recognize in the classical music world. So a forgotten woman in those days. So Europe at that time had a lot of things going on. And people from very small countries, as small as Portugal and Holland, came all the way sailing in ships to the eastern coast of India. This is the story of the East India Company. It almost beggars belief that somebody who formed a company could colonize an entire continent. And from some of it came good stuff, and from some of it came very strange stuff, as we all know. So the East India Company was formed by some merchants who wanted to essentially trade along the Indian Ocean. They came when the Mughals were ruling India, and they also colonized, and they also had interests both in the East Indies and in China. Later on, as you know, there were so many difficulties with the East India Company. Queen Victoria likes to be remembered as the Empress of India, and she considered India the jewel in the crown for very many reasons, as we all know, from spice trade to the gems. So that was the only chap who was our friendly face, the chap who gave us ether. So when the East India Company was first formed, we did a lot of trade in silk and spices. and they were all the beginnings of the British Empire. The Portuguese who came there traded, and they came earlier than the East India Company. The Dutch who came, who formed the United East India Company, also came earlier. And there was a very small French interest, which still continued to be there as Pondicherry for a very long time. And following the battles of Plassey and Buxar, you know, they established their power to an even greater degree. Madras is relatively new, as Chennai was originally called Madras. In 1500, it was a very small place. But currently we know Moorfields as an eye hospital, which is quite big in the National Health Trust. And it's part of the UCL Institute of Ophthalmology, and it's part of that university. And it is the oldest and largest eye hospital in Europe. And in 1805, when Moorfields was first established by John Cunningham Saunders, he was assisted by John Richard Farey. Apparently, he had to write a special note saying, I can't cope with all the patients with eye diseases. Could you please find me an assistant? That's when John Richards joined. So it existed at a previous site, and it's been relocated to its current location. But it's also celebrated 200 years in 2005, which was a very big note. Currently, the statues of these two men are relegated to a small area because the space they existed in has been cleared to form yet another clinic. As you know, we're always running out of space and moving corridor space. So this was the founder of the Moorfields Eye Hospital a long time ago. And Travers was one of the ophthalmic surgeons there, and he worked for the East India Company. And Richardson and Travers did early cataract surgery. We should also think of Saunders as quite an interesting character because he introduced dilation of the pupil so that we could operate in a much easier fashion. So he introduced belladonna, and thus pupils were dilated. So in the previous talk, we've been hearing of intracameral dilation. I think in these days, it was lucky that he could drop something on the corneal surface for dilation. He began his life as a chap who was interested in trachoma, trying to treat all the people who were coming back from Egypt after the wars in about 1913. And that's how he became interested in ophthalmology and established the hospital at the time. They were basically hospitals for people returning from the wars. And the people in the cities used it when they got into trouble. He also wrote a book. It also helps us realize that ophthalmology wasn't a very paying profession because his poor widow had to survive on the remuneration got from selling his book after he died. And following that, John Richards took over and he continued to work. But even in the very early days, Moorfields has been training a lot of pupils and has been training people who came from UK, India, Portugal, Germany, America, and also the Army and the Navy. The first people who operated, did cataract surgery were trained in Moorfields and then went on to operate apparently in America because there was nobody else to do it there and they were scared to take that long, arduous journey, especially for their parents to come to England to be operated. Following that, in 10 years, more than 1,000 people were trained and they went away to practice ophthalmology in various corners of the world. And that was quite an interesting thing. Currently, we have a lot of trainees who go to other parts of the world, also in their thousands to come back and disseminate and practice ophthalmology. So it's rather an exciting time of understanding nursing, ophthalmology, and the way we sort of set about imparting things to our students and them taking it on and running forwards. That's a picture of Chennai along the coast and the eye hospital that was established there. Now, this too was established by the East India Company by a person who came all the way from Richardson, who was part of the East India Company, who came and opened this hospital here for the army people who were in the cantonment areas in the Madras Presidency at that time. And the General Hospital in Chennai, which is the government general hospital currently, and it looks like that now, existed for a very long time. It started in 1664. It also tells us how ophthalmology was neglected for such a long time as a particular specialty because it took them quite a long time to have an eye hospital or to have an eye department exclusively. That's Madras in the 1920s, looking quite different than it does now. So the start of the eye hospital in Madras was by Richardson, and it was a Madras Eye Infirmary. It was renamed, and the people who trained here also went on to train elsewhere. But following the success of the Madras hospital, 2 more people came from England, both to Bombay and to Calcutta, to open these very old hospitals there as well. So I think that this hospital too is now affiliated to the Madras University, and it's called the Regional Institute of Ophthalmology now. And it too is a very big hospital, and it had a lot of beds in the old days, more than 1,000 beds. We, of course, have all limited our inpatient care now. And as the Madras Eye Hospital formed, it was run by a lot of people from British India, actually, who came across the seas. There were very few Indians at that time who were in charge of the hospital. So only following independence or near independence that the Indians took over. And the names who were quite important were, Elliot, who invented the sclerotrephining that we know quite well, and Koman Nair and Muthaya, whose pictures still hang in the hallways, and who were important because they even started the eye bank in India. But however, the rest of general medicine was progressing quite rapidly in 1664 at the Government General Hospital. So there was a lot of collaboration between the ophthalmologists and the general doctors in the hospital. And the General Hospital was apparently a really large hospital, and it too took care of the Army Corps at that time. Madras Medical College was founded in 1835, and it became part, the eye hospital was affiliated quite extraordinarily to it. The clock that you see in the picture was the anniversary present on the 200th anniversary that the 100th anniversary that stuck it there. This was the Moorfields waiting room a long time ago. The patients were many, they all had 2 eyes, and they had very few doctors. Sadly, the same story exists even now. We all seem to be overworked and looking at hundreds of patients. The cataract surgical suite at that time. And Moorfields, by that time, had also changed. It now has a children's hospital, which was started in 2007, and it's expecting to relocate yet again because it's outgrown its quarters. This is the Institute of Ophthalmology, where the research takes place, and it's very close to Moorfields. It's just another wing in the same hospital, and this has changed remarkably because you can see your patients and do your research all in the same building, basically. Here's another Moorfields person who invented the cryoprobe, Percy Amolis. We all know him because he let us defreeze and freeze the retinal cryoprobe. It also helped with cataract surgery, and the gynecologists used it too. So people who trained in these places took away things when they went away and invented things. This is actually a board which hangs in the director's room in the Government General Hospital. It lists all the superintendents who were there. And some of them did great things, some of them didn't do great things, some of them wished they had done great things. But nevertheless, they hang, along with their counterparts who lived and ruled there for many years. And we hope that they all give us something to take away as we progress into the next 200 years of ophthalmology, because they did a lot of pioneering things there. And you might recognize many of these people. They have walked these halls. This is the eye hospital. The one across the hall is the old building, which is the red building you saw in the earlier picture, and the new building, which is towards the side where I'm standing. More recently, they were able to broadcast surgery and it to Moscow. So things progress. This dilapidated building is the original Elliott School building and the original red building. Sadly, it's a listed building, and there's been a lot of controversy as to who is going to rebuild it and restore it. Is it going to be the archaeologists, or is it going to be the eye doctors? So the debate continues. Those are the corridors which we walked in when we were students going to Elliott School to go to our lessons when we had finished our clinical work. And it's a very beautiful building. It is very remarkably similar to the government maternity hospital in Madras. And it's also quite similar, close to the corporation building or the Ripon buildings that still exist and stand tall in Madras at this time. So we walked these corridors and we lived in these places. That's a picture of Duke Elder, who published those several volumes of ophthalmology that some of us are familiar with. He's still very beloved in the Regional Institute of Ophthalmology, and strangely not so beloved in Moorfields, where he lived and worked for a very long time. So I want to just say that there are many things that happened out of collaborations with these places. They haven't been a lot, but we hope things will change in the future. And those are some of the things that came out of the hospital, the Madras eye, which is a viral conjunctivitis. The Regional Institute of Ophthalmology these days trains a lot of people. It has 30 postgraduates and a lot of MS students, and it continues to change people in surgery. In recent times, we have a lot of fellows visiting CEOs between the two hospitals, observers and trainees who cross the continents, and trainees of various kinds and consultants. Moorfields published this book, as a historic bit, and we celebrated the 200 years. But I just want to leave you thinking that ophthalmology has been around a long time, so we do care for eyes. And although things existed in a different fashion many years ago, I'm sure the next 200 years might be quite magnificent too. Thanks very much.
Thank you. Thank you so much, Dr. Sharla. And it's been quite nostalgic to look at those pictures, because I did my medical school in Chennai, and those were some of the corridors which I had walked around as a young medical student way back. And when I did my MBBS out there, I lived next to that old hospital, and it is indeed a privilege to talk about and have seen and experienced Elliott School and the wonderful wards and the building of Easter years. Thank you so much for taking us back. Yes.
So let's move on with the next speaker, Dr. Arif, who will be talking to us on corneal biomechanics and use of Corvis ST and Pentacum. So that's simply, decades of science, there we leap, and we've just seen from this, from the previous speaker's slides, ophthalmology 200 years ago, and now we'll be seeing ophthalmology 200 years later. Dr. Arif is here.
It's nice to know about the history of Moorfields, and they have expanded outside Dubai, outside the UK also, and they have opened 2 branches in Abu Dhabi and Dubai where I'm working, not in the same institute. At the onset, I also thank the organizing committee to invite me all the way from Dubai to speak and be part of this celebration, celebrating 200 years of Indian ophthalmology. And it's good to be back to India and speaking on front of the august audience. So today I'll be talking mainly about the use of Corvis ST, the instrument used for the diagnosing and evaluating the corneal biomechanics. The reason I took this topic is, as you all know, keratoconus is quite prevalent in the Middle East and even in Asian population. And it's an important condition which has to be ruled out before going for any laser vision correction surgery. So the detection of the mild or subclinical forms of ectatic corneal disease has gained relevance because these cases have high risk of iatrogenic progressive ectasia. This ectasia progression occurs due to the biomechanical decompensation of the corneal stroma, which is related to the preoperative predisposition. So these things has to be evaluated before going for the procedure. Keratoconus is a progressive non-inflammatory bilateral condition which is ectatic corneal disease characterized by paraxial stromal thickening and weakening which leads to a corneal surface distortion. Now the new theory which is put forward for the formation of keratoconus is the focal reduction in the corneal biomechanics. This will result in the thinning of and weakening areas leading to, and the focal reduction in elastic modules causes deformation for the same load. So why biomechanical properties are important? The dynamic corneal response which leads to the corneal stiffness, this evaluating is important to calculate the biomechanical intraocular pressure, because these pressure changes whenever you do the refractive procedures. See the effect of corneal cross-linking to diagnose early keratoconus, also helpful in evaluating the glaucoma risk factors, treatment of glaucoma, and also the improved prediction of refractive outcome. So this Corvis ST, it's a non-contact tonometer with a collimated L pulse with consistent pressure profile. It acquires almost 4,300 frames within few seconds, covering almost 8.5 millimeters of the cornea in one shot. So during this measurement, an L-puff deforms the cornea inward to a first applanation, which goes into a concave shape to a point where the highest concavity is achieved. Afterwards, the cornea comes back to its outward position and applanates, causes a second applanation before coming down to its natural position. Once the measurement is performed, the device provides a set of deformation parameters. So there are two sets of parameters which are formed. One is the deformation and second is the deflection parameters. And I will not be going into detail about the different parameters which were seen. The important four I will be highlighting it. So as you see, these are the deflection and deformation parameters. Once the cornea goes down, forms a concave, and then it comes back and forms a convex and comes to its original position. So it's a deformation parameters and then the deflection. Vinci Cura is a scientist, is a doctor who plays an important role in evaluating one screening report, which is known as the Vinci Cura screening report. It's a new display of Corvis ST in a single interface. It compares the normative values to the imported exams, as well as to include an index which helps us in separating the normal from the keratogenic patients. So, yeah, these are the four parameters which are important, which I'll be explaining you. This four parameters plays an important role, and as you all know, there are the the white zone. So any reports which comes in this white zone is a normal, and if the report comes in the gray zone, that shows the chances of keratoconus or ectatic conditions are high. This test is not helpful in evaluating the progression of the disease. It will be only helpful in diagnosing the condition. So the four parameters are first is the DA ratio, that is the deformation amplitude ratio, which is a central deformation ratio between the vertical displacement at the apex and at 2 millimeters. The second is the integrated radius, which is area under the inverse curve, which is compared to the time curve. The third is the Ambrosier relational thickness. It's a thickness profile in the temporal nasal direction. There are too much of physics involved in it, which I'll not be going into detail. And the last is the stiffness parameters at A1 interval. These parameters is also helpful when you're treating the keratoconus, like cross-linking. So you measure the stiffness parameters, proceed for the cross-linking, and then after 1 month, 3 months, start evaluating it. So you'll be able to document that the stiffness parameters does change. The cornea becomes more stiffer after the procedure. Once these four parameters are calculated, the new biomechanical index, that is the Corvis biomechanical index, is calculated. This is the important indicator of what is the biomechanics of corneal biomechanics is. It is based on the corneal thickness profile and the deformation parameters. It is helpful to separate the normal and the keratogenic patients. Thus, the CBI includes all the parameters which I have explained to it. This is the last thing is the CBI. It's a simple to interpret. The green zone is the normal zone. The yellow is the borderline. Once it goes more than 0.5, there is a chance, there is a more predisposition of ectatic condition. The next important parameter is the Ballen-Ambrosier display, which is calculated by using a pentacam HR. It combines both the anterior and the posterior elevation data and the pachymetric data to provide a three-dimensional topographic representation of the corneal shape. So this D value, which is calculated at the end, plays an important role. So once the tomographic images are taken from the pentacam and the biomechanical index calculated from the Corvis ST, both these parameters are helpful to generate a third indicator that is known as the tomographic and biomechanical index. It's a novel parameter based on the robust and innovative combination of data which is derived from the Scheimpflug image of pentacam and the biomechanical analysis. It results in higher accuracy for detecting ectatic conditions. So the left will be giving these are the images taken from the pentacam HR, from the Corvis ST. These are the four maps from the pentacam. So the CBI is calculated by using the Corvis ST. The BAD is evaluated by using the pentacam HR, and the final score is the TBI, which is the tomographic biomechanical index. So this is helpful in cases where there is a borderline cases where you feel that the pentacam HR is normal. But once you calculate and see the biomechanics, it will helpful and detecting whether to go ahead and do the procedure, laser vision correction. So these are the small few cases which we can see the steepening in the right eye on pentacam. You can see the changes both in the front and the back surface. And once you do the Corvus ST, you can see the score of 1. And even in the CBI, you can see it goes in the red zone. This is another report where you see the pentacam shows normal green areas, even the left, but you see slight steepening, not too much in the left eye. But when you do the Corvus and tries to evaluate, you see the TBI is going in red zone. So it's always better to avoid patients going for laser vision correction. This is a straightforward case in the left eye showing steepening. Now this case I want to highlight, the right eye was evaluated, it shows green, fit for the surgery. And when this patient's left eye was seen, you can see the steepening. And when the Corvus ST also was done, for the right eye you can see the CBI going in red zone and TBI also in red zone. So thus this patient should be avoided, laser vision correction surgery should be avoided. This is another case where the borderline, the bad D goes in the yellow zone. Thus, the diagnosis of ectatic disorders started from slit lamp retinoscopy. It went into topography, then tomography, and now it's integrated tomography and the biomechanics using the Corvus ST. Thus, clinical evaluation of the in vivo corneal biomechanics is a challenging but promising area of contemporary ophthalmology. Understanding the biomechanical corneal deformation behavior might be useful in numerous clinical situations, including glaucoma and corneal ectatic diseases. While we can recognize significant improvements over the past years, additional research is still needed. Nevertheless, we anticipate an accelerated growth in knowledge in this field in the next years to come. There are some fallacy even in the Corvus ST, where the ORA comes to an important role, but by acquiring this machine and with the Aventacam HR, many cases of iatrogenic ectatic disorders can be avoided when you go for the laser vision correction. I welcome you all to Dubai and to this vibrant city, showing the different landmarks. This is the hospital where I'm working right now in Dubai. Thank you.
Thank you. Next, I call upon Professor Hossam Ziada from Al-Azhar University, Egypt.
Hello, everybody. First of all, I want to thank all respectful chairperson for giving me this chance to be in this great meeting. And it's the second time for me presenting in India. Corneal biomechanics, what do they offer? Really, I'm lucky to look after Dr. Arif because he helped me to skip a lot of my slides. The concept of the biomechanics that the cornea has its own viscoelasticity and the viscous and the elastic properties of the cornea is the aim of the corneal the corneal structural formula, and on the other hand, how to deal with the corneal disorders and how to judge your dealing with the cornea during preparation for the refractive surgery. The elasticity means that the ability of the body to dissipate and recoil energy, absorption of any stress and dissipation, again, is the property of the elasticity, of the definition of the elasticity in brief. But the viscosity is the ability of a solution or substance to resist flowing for a time and then they flow, like the OPD viscoelastic used in cataract surgeries. So the viscoelasticity or the viscoelastic properties of the cornea, they are responsible for the cross-linkage of the corneal stromal collagen, and on the other side, the tensile strength of the cornea, which is the key word of the corneal hysteresis. Later on, I will discuss it about. So let's summarize that in 3 words: elasticity, plasticity, and viscosity. I mentioned about the definition of elasticity, the ability of the body to absorb and dissipate again the stress. Plasticity is muchly different than the viscosity, elasticity. Elasticity and plasticity, the same word and the same pressure effect. But the elasticity means that this subject or this tissue can recoil at once without any delay. But the plasticity means that the subject, when any subject or any tissue subjected to a stress, he will be indented for a time. It is the ability of this tissue to modulate and to be deformed on chronic stressing. And the viscosity is the ability of the body to resist for a time and then flow. It's not permanent resistance to the pushing stress, and also it is indentable with distribution and washing out like the viscoelastic. And say, as I mentioned, this is the key words of the corneal hysteresis and the corneal resistance factor. In this picture, I want to give an idea about the intimacy and the intermingling structure of the anterior corneal stroma. It's the main part responsible for the corneal integrity, the anterior stroma, where the collagen lamellae are arranged in intermingling fashion, but the posterior stroma is strictly arranged in a parallel fashion. And so the anterior corneal stroma, as the part touched with the corneal refractive surgeries, is decreased. The ablation by the laser takes from the anterior corneal stroma, and so the deeper the ablation depth, the more weak the cornea, the decrease in the thickness of the anterior corneal stroma. The measurements of the corneal biomechanics depends on the corneal hysteresis, the corneal resistance factor, and the IOP, either cornea compensated or not compensated. The aim of the measure depends on the non-contact tonometer and IOP-dependent procedures. In a way, whether by the Corvus standard or by the aura, which is the older one. About the corneal hysteresis, it is defined by, it's a Greek word, means lagging behind. The cornea by eject or by jet of air or pulsed jet of air takes the cornea backwards, and then the cornea recoils and regain its normal shape again. And according to the depth of indentation, according to the power of resistance, and according to the speed of the recoil, the corneal biomechanics are defined, especially by the Corvus standard, which is much better and more helpful than the aura. But actually, remind this word, it is not stiffness. The corneal hysteresis doesn't mean stiffness, but the cornea is not stiff. It's viscoelastic tissue. I will skip these slides because they are shown by my dear colleague, and this is a print out of both the aura on the left and the Corvus on the right. The aura gives us about the corneal hysteresis, the corneal resistance factor, and the IOP, but actually the Corvus standard gives a lot of information more than the aura, so it's more helpful than the aura. The TBI, the combination of both together, the Schindler camera, the topography, and the corneal tomography, and the corneal biomechanical measurements two in one machine, so you don't need to send your patient to another device. What does they offer for you? The corneal biomechanics will help you if you are a refractive surgeon, and also they will help you if you are a glaucoma surgeon. What should refractive surgeon know? The refractive surgeon should know everything about the corneal hysteresis, the corneal resistance factor, and the IOP with also the central corneal thickness and TBI. In simple words, the corneal biomechanics will say you have to stop or you can go for the refractive surgery. To go for keratorefractive surgery or to discharge your patient and giving him the advice not to do that. Secondly, we have to remember from the corneal biomechanics view, you have to remember this very important issue, which is the PTA, percentage of tissue altered, which is based on the corneal biomechanical changes after the keratorefractive surgeries. By Marconi Santiago et al. 2014, they bought this formula. The PTA, or the percentage of the tissue altered expected after doing this refractive procedure, equals to the flap thickness, the ablation depth divided by the central corneal thickness. And so they bought this rule. The PTA more than 35% is a very high risk of developing post-LASIK ectasia, and with 100% sensitivity of more than 40%. So I bought this margin for my work. If I got by this formula that my patient PTA will be more than 35, I will change my plan for this patient. So along my time of working in the refractive surgery, following this rule and following the rule of the flap thickness and residual stromal bed, I was lucky to get just one case of post-LASIK ectasia in preoperatively normal patient during my study and my observation on about 500 cases of LASIK in high myopic patients. So the preoperative low corneal thickness in high myopic errors are risk factors even in normal corneal topography. And in quick manner, these in refractive surgery too, you can define, you can know and follow up your patients pre and after your procedures for the keratoconus. Yeah, you may find that the normal, from this study, the normal corneal hysteresis was between 8 to 11.5, and in keratoconus, it was between 5.7 to 7.7, and in the intracorneal rings, in the corneal rings, the corneal hysteresis is grown up from 7.0 to 9.5, which becomes again in the normal range. But surprisingly, you may find that the post-RK, the corneal hysteresis is much lower than the patients with keratoconus and also the patients with keratoectasia. And the question, while despite of the very low corneal hysteresis, the patients with RK, which is radial keratotomy, they don't develop post-RK ectasia. The answer in one, yeah, okay, just 1 minute, please. The answer in simple way that the radial keratotomy incisions all around the cornea with an equal distribution of the weakening powers, not shifted to one side than the others. So the post-LASIK ectasia may be protrusion in the inferior cornea, while the RK, the weakness is distributed all over the cornea. The second this study, they concluded that the same. And finally, the detection of the keratoconus, the subclinical keratoconus, by studying the corneal hysteresis and the corneal resistant factors. And they found this study that the KMI, which is the keratoconus matching index, is higher, is lower in is higher in the group 0, where the corneal hysteresis is very high. The KMI is in inverse correlation with the corneal hysteresis. And they found again at the form first keratoconus will be diagnosed or suspected when the keratoconus matching index is less than 0.5, and the corneal hysteresis less than 8, and the corneal resistance factor less than 7, and the score of this examination less than 5. And finally, before finishing my word, you can choose as a surgeon to be like Remus, who broke the hearts of Egyptian people before the World Cup by injury of Mo Salah, or to be at the end like the Mo Salah taking this vacation in Maldives. You are the surgeon, and you have to protect your patients not to be victims, and to be assured about your patients here and away. And thank you very much.
Thank you, Dr. Hussam. And I'm sure Mo Salah is going to recover well and give it back the next time.
Okay, thank you.
So now request Dr. Antonio Carlos to come and talk about the current treatment aspects in keratoconus.
I want to thank Professor Dr. Natarajan, Professor Sharma, and I thanks the invite of this glorious conference. I'm from Brazil, so far away, so far, and 25 hours traveling, and it's my second time in India, and I love it. I will speak about the different aspects in treatment of keratoconus. The corneal, first I want to talk about the corneal properties, the viscoelasticity, viscoelasticity and biomechanics. In the past, we don't know, I think the cornea is a more rigid structure. But now I know that the corneal have a great viscoelasticity and a biomechanics property. Other colleagues explain very well about these two properties. And biomechanics is a response of pressure in the cornea, and the response of this effort give us some interesting treatment. Okay. The diagnosis of keratoconus, we have a topography, a tomography, and a biomechanics. I think one slide, don't, I return to another slide, okay. Let me speak about keratoconus treatments. And we have contact lenses, rigid, gas permeable, and gas permeable scleral. The intraocular rings, like called Intex, and corneal collagen crosslink that we use riboflavin and ultraviolet light. The riboflavin and ultraviolet lights creating new links between collagen fibers. And we have two types of crosslink. The epi-off is a classic procedure, and epi-on with we use the iontophoresis. And the iontophoresis can make the riboflavin pass into a epithelial, a conservate epithelium, and introduce the riboflavin in the corneal stroma. The crosslink associate treatment, you have a PRK. The PRK only makes sense if we associate it with crosslink. And we need to first make the PRK and then the crosslink, because if do the not the same time, and I think if you inverse crosslink and then PRK, we will destroy the crosslink treatment. Okay. The Intex, it's for patients with low myopia. We reserve this treatment for these patients. And association with phakic IOs and iostoric give a very good treatment for the patient. Okay. Now I put an case of complication of crosslink, and we can see the scars in the cornea and opacification of the cornea, and it's a bad result for crosslink. And now an Intex complication, and we can see the ring, the exteriorization of the ring caused an corneal edema and a low vision. About keratoconus treatment, we talk about refractive surgery in keratoconus, and it's like I said, the refractive surgery makes sense if we associate with crosslink, okay? And the iris support EOS implantation and toric lenses with a good result. The keratoplasty is another treatment, and a femtosecond laser associated with other procedure like Intex that we can do with more precision the implant of the ring, and in fact second in the keratoplasty, and lamellar and total keratoplasty. I want to can you help me, please? Can you help me, please? Okay. There are one slide that don't pass is the epidemiology and the etiology of keratoconus. And the epidemiology interesting because in the past we have one case of keratoconus and in 2,000 patients. But in recent study of Professor Torres Neto and Professor Hafezi, they published in the British Journal of Ophthalmology a work that they study with biomechanics and tomography pediatric patients. I recommend this to read this study because it's interesting, and he with these two procedures can diagnostic the early keratoconus, and the range is that the patients of 6 to 21 years, they found about 5% of these patients who expect keratoconus disease. Okay.
Professor, could you summarize because we are running out of time?
We have a little problem with the keynote.
Professor Carlos, could you summarize?
And we will talk about the future of the treatment of keratoconus. We need to improve safer treatment and new protocols for crosslink to make this procedure more safe, and a new studies in biomechanics and genetic studies, and I can speak about genetic treatment too, and a little talk about teleophthalmology. It's an interesting study because we can, India is a big country, Brazil is a big country, and you have some colleagues that is so far from reach centers of ophthalmology, okay? And then we can pass some information to the big centers. To the big centers, orient the treatment of the patient. For example, we have in the mobile some adapters. Okay. Wait. Oh, yeah. Okay. Some adapters that we can photograph the eye, and for example, here is two kinds. One that photograph the eye and the sleep lamp, and other is a retinal camera. In my institute, we make a big work about retinopathy, diabetic, and many colleagues so far from a big center send the images of a camera, a retinal camera,
Professor
and
Carlos,
to return.
Professor Carlos, we are running out of time.
And to return, we send to them the treatment. About we stood about 1,050 patients, colleagues and patients too. Okay, and I want to one more thanks the invite, and I'm very happy to stay here. Okay?
Thank you, Dr. Carlos. I'm sure if we all have anything, questions, we'll talk to him after the session is over. Now
I call upon Dr. Bjorn Pacek to talk to us on corneal presbyopia treatments. Over to you, Dr. Pacek.
To present you our studies, prospective studies of corneal presbyopia treatment. So it is a presbyLASIK multifocal corneal approach. What we do is an addition in the 3 to 6 millimeter zone, in the 3 millimeter zone. It is an addition for the near. That's the issue of this study, to perform this procedure. It is the algorithm is like this. You perform first the normal myopia or hyperopic procedure, and then at the end of the algorithm you perform this 3 to 6 millimeter zone steepness of the 3 millimeter central zone. So that was the last study we performed for myopic patients. It is said myopic patients which were treated with presbyLASIK. There were 72 eyes, and the results were very interesting. You see, already of the beginning, after 1 week, we have already reached a quite very well visual acuity of Lockmore visual acuity of 0.12, and it approaches more to at 0 after 6 months. The non-dominant eye is targeted at 0.5 dioptries as a target refraction. The dominant eyes at 0 refraction. The benefit for these patients are forever in the intermediate distance. We see that for the computer distance, they have a very well visual acuity already from the first day. It is said also during all the time of the follow-up. And for the near, the dominant eye is a little bit less because we put it for the far, and the non-dominant a little bit more for the near. It is a difference of 0.5 dioptries, so they have a quite well visual acuity also during the follow-up. These were the myopic patients. This is autodynamic with the hieropic patients, we will see. So we also performed this study of the femtosecond laser, femtoLASIK with, for hyperopia, of 38 eyes, 19 patients. And the normal inclusion-exclusion criteria as for LASIK are done. And what we have seen that the visual acuity improves during the 6 months. It is said it takes time for the far vision for hyperopic patients. Intermediate visual acuity is very well. Also for the near, from the first day, they have a very high quality of near vision. What we have seen, you have two components. You see here we have an overcorrection, that's normal. For hyperopic patients, we have an overcorrection, so in the myopia. So it shifts slowly during the follow-up at more or less 0 dioptries or 0.5 in the non-dominant eyes. So it is very important to explain to patients that it takes time during the follow-up, that for the far the vision increases slowly. For the end, a special case, we have this acanthamoeba, you see that. That was in the 18th, so it was really magic. Everybody performs it. But now, these patients are elderly, 16 years old, and have the problem with the shift in the hyperopia with this radiokeratotomy. And the second one is the presbyopia. So you have this patient who's make the procedure in, I think, in Belgium. So what we have performed this procedure with the femtosecond laser, make a LASIK cut. And so we were curious if the cut is very well done. We see that the mobilization's easily. And here you see the cuts in the deepness of the stroma. And now you see we perform the hyperopia correction, and then in the 3 mm zone, we make a steepness on the central part of the cornea. So she gets a presby LASIK. What we have seen the first day, okay, we started at 0.3, non-corrected visual acuity, and then it decreases slowly. But it was very interesting to see also very similar results. We have at the end for the far a visual acuity of 0.1. For the intermediate visual distance, a little bit less here on the dominant left eye. And for the knee, it was also quite well. It is 0.8. It's a quite good result, I think, for this patient. If we come to the summary, our study was based on a new presbyopia profile. This new argument creates a multifocal zone without transition zone through the elevation of the 3 mm zone in the center. This center is for the near. And what is also, if you create this correction, you create also spherical aberration. So this treatment should be performed customized. It is said you treat on the same time also the spherical aberration. And the aspherical treatment will be in the 3 to 6 mm zone, and the multifocality is also in this zone. Conclusion for this procedure, our correction algorithms is that dominant eyes is corrected for the far with multifocality, and non-dominant a little bit less in the minus 0.5 dioptry, so that we get the last centimeter for near. These techniques provide spectacular independence, but not 100%, you know. It is the target 95%. It depends also of the profession of the patient. Thank you very much for your attention.
Thank you very much, Dr. Wajik, and that was a wonderful talk. And I thank all the speakers for taking out time and giving us excellent presentations. May I call the speakers on to the front for a photograph, please?